Hello, this is Olga Adler from Austin Businesswoman, and today we're talking about a very important topic of senior wellness and geriatric care. We're going to talk about common issues that are faced by our senior citizens, care options, living with conditions like dementia, talking about Medicare, talking about the best practices of care, and helping your elderly parents or family members or yourselves. And today with me is an amazing panel of experts from different fields who have a lot to contribute to this subject. I'd like to introduce first Courtney Mayne. Hi, Courtney.
Hey everyone, my name is Courtney Mayne. I am currently an activities professional and a dementia specialist. A little bit about me, I've worked in hospitality for over 6 years, and I decided I wanted to do something that I felt really passionate about. I made the switch over to senior care. It's been a little over 4 years now. It's been the best decision I've ever made. I currently am an activities professional in a memory care setting. But I'm also working on my side business, which is called Supermain, and I'm focusing on improving the quality of life for seniors through training and education of activity professionals, while also helping families at home through the dementia journey. So I'm kind of doing a little bit of everything right now, but I'm really excited to be here, and I hope we can answer some of your questions today.
Thank you, Courtney. Happy to have you on the panel.
Thank you.
Next one is Anna McMaster.
Hi, everyone. I'm Anna McMaster. I own CarePatrol of Austin. CarePatrol has been around for more than 25 years, and we exist to help families find assisted living, independent living, and memory care. It's very similar to being a real estate agent, but specializing in senior living. So with my clients, I guide them through the whole process. I often tour with them. I help them get connected to the right resources. And the best news about CarePatrol is that it's completely free for the families I work with. I get paid with the providers in my network, and I'm really happy to be here. Thank you, Olga, for having me.
Thank you, Anna. The next one is Michelle Howard.
Hi, everybody. I'm so happy to be here today and work with these talented young ladies. I am the owner of Southern Hospitality Home. We are a small type B assisted living, licensed for 15 residents at maximum capacity. We are located in central Austin and Allendale, and I've owned Southern Hospitality for 8 years. Prior to that, I worked in Medicare certified home health and hospice for 6 years before that. Thank you.
Thank you. Thank you, Michelle. The next is Dana Lassman. Sorry if I mispronounced
it. Hi, everybody. I am very happy to be here. I am Medicare Dana. That's my little nickname, MedicareDana.com, and I am a Medicare specialist. And I spend a lot of time educating folks on the Medicare program, the options that they have, what the different programs look like, the cost, planning for future. I work a lot with people that are just about to enroll in Medicare, but also people that are already on Medicare to make sure that their plans are being reviewed, that the costs are in line with the fixed income as we retire, and making sure that our senior population have all the information, all the resources, and accurate information at their fingertips so that they're not trying to figure out this Medicare maze without anyone in their corner. And similar to Anna, my services are completely free to the client and families as well. I get paid by the insurance company. So it's always good to reach out and make sure that you're just on a good plan or that your family member is on a good plan, and so that you can feel confident with that.
Thank you, Dana. And the last but not the least, Michelle Coffey.
Hi, my name is Michelle Coffey. I'm an advanced practice nurse. I am the Chief Clinical Officer with Austin Geriatric Specialists. We provide geriatric care in a variety of settings, including palliative consults at local hospitals, skilled nursing facilities, assisted livings like Southern Hospitality there, and we also have a home visit program. Our providers provide excellent and high quality geriatric care in our area. We have about 50 advanced practice nurses and 10 physicians serving thousands of patients in the Central Texas area.
Thank you for joining us. I'd like to start with our questions because we have a lot of questions. And the first one would be, in general, let's talk about the most common issues that people who are 60 years and older face on a daily basis. And it can be their physical health, their mental health, or any other issues. I'd like to ask Anna to answer this question first.
Well, from my point of view, I see clients that are ready to take the next step into getting some care. So typically, what I'm seeing is people at maybe the early stages of dementia, or I'm seeing some kind of mobility issue that's related to a fall, and they need to move into a community-based situation where they can get help. But I do think that throughout the pandemic, one of the most common things that I've seen is actually depression in older adults. That's affecting everything. That's not just mental health, that's physical health, that's emotional health, and can often lead to earlier dementia coming on. But anytime there is a fall or kind of any kind of acute situation, it can often snowball into bigger issues. So the trick is to kind of observe the red flags so that you can be on top of it when a situation like that does come up.
Mm-hmm. Yeah, totally. And the past year has been probably the most difficult year for young and elder. I would like to ask Michelle Coffey if she could add something based on the experience of your practice.
Sure. From a medical perspective, typically around the ages of 60 and older is when we see medical issues that have been maybe at the surface level for a while starting to cause a little bit more issues. So it's when someone who has maybe had hypertension or high blood pressure or high cholesterol for many years that has just been part of their daily life. But as you get older, you start to have more wear and tear on the body. So that's when you have a higher risk for things like stroke, and you start seeing some possible signs of dementia. And you see the cumulative aspects of those underlying medical issues for many years. Diabetes is an excellent example. It's the silent killer. You don't feel it for many years, but around the age of 60, 65 is when those things, they start to catch up with you. And that is when you start seeing sort of the effects of all of those lifelong illnesses start to manifest.
Yeah, it sounds like diabetes in particular. A lot of people in the community, I hear stories about people who are 30 something years and they're pre-diabetic, and they discovered it on accident because they just happened to do their well check. And it's just crazy how many people suffer from this condition and don't know. What would be, and this is a question for everyone, since you work with people from different perspectives, what are the red flags that family members or people themselves should pay attention to when something changes in their health? When is the good idea to go see a doctor about it? Go ahead.
Sure. From a medical perspective, I like to separate those things into physical changes and cognitive changes. And, some physical red flags that are easy for some people to pick up on are things like changes in their walking speed or their gait, sort of how someone walks. Do they start to need an assistive device? And many times that can be helpful with longer distances. But when they start needing those devices for shorter distances, that can be a concerning sign. One common tool we use in geriatrics is called the get up and go test. And that is simply how long it takes for someone to get out of a chair and start walking. And longer durations with that get up and go actually is associated with worsening debility and healthcare outcomes. But now cognitively, it can be a little more difficult to see the changes, especially if you're incredibly close with that loved one it's very difficult to see those changes from day to day. Some key things to look for are repetitious stories. Sometimes folks will get caught up in a loop of a story, and that can be a red flag. But the best way, in my opinion, to really identify concerns, if you are concerned or suspicious, is to actually get your loved one in a new situation, something different than their norm, and see how things go. Are they able to adapt? Do they get a little bit more confused? Because the early signs of dementia can easily be masked with routines, and getting them out of that routine can really help you identify if there are something that you need to investigate further.
And I would add to that, and I always tell people before the holidays, before they go visit their parents at Thanksgiving or Christmas, just take a look around in their house. Are there stacks of unopened mail? Is the house maybe a little bit dirtier than it used to be? Maybe they're not doing the hobby that they used to love. Those kind of little things that used to bring them joy or they did easily in their daily life, are they still completing those activities appropriately? Yeah.
The other thing I'd like to add to this as well is this is such a great conversation to be had, because I think that this is really hard for both the parent and the child of this situation. And it's really hard to start the conversations, what to look for. So as Anna was saying, when you visit, these are some of the things to look for, but also to start having some dialogues with your parents. And a lot of our aging parents are of an age where they keep things really close to the chest, which is tough. And if you ask questions, they might feel it's a little bit of interrogation, and they're proud and they don't want to burden you with, their woes or whatnot. That's a generation a lot of our parents are at, our aging parents. But it's really important to start having those conversations just about, I'm just wanting to get information. You can use commercials if it's the Medicare space. I see all this information. It's confusing. If I'm confused, you might be confused. I just want to make sure that you're taken care of, or you're seeing doctors and things like that, to really start these conversations, because otherwise it is really easy to miss it. And then sometimes it's too late and it's harder to pick up those pieces, without maybe being able to see it prior, and then looking at the resources in the community to get the help, or get, maybe even it's a bar put into the shower, things like that, to help as there are some decline, not get worse.
Dana, I also wanted to ask you, since your specialty is Medicare, what are the unpleasant surprises that a lot of people who start needing care in the elderly age find when they start getting help through Medicare? Are there any pitfalls, any things that people should know ahead of time, or know what they can count on when times?
Yeah, definitely. The biggest, I would say, misconception or misunderstanding with Medicare is that there's two programs under the Medicare program, the federal program. It's Original Medicare and Medicare Advantage, and they're very different programs. The way that people get their insurance coverage, the cost, what is or isn't approved or allowed, are very, very different, which is why we spend so much time on the educational portion. Because if someone doesn't understand that they can't get the coverage that they need because they're in a different program, I'm seeing a lot of people shaking their heads, you can't get all the coverage on a Medicare Advantage plan, for example, that you might get on Original Medicare. And if people don't know that, then there could be a lot of ramifications financially and medically in terms of what can be covered, and of course for the family as well. So really educating on what the program options are, talking to a trusted source, talking to doctors as well, because they're very familiar with it, as are, anyone. We're talking about care of the elderly. Long-term care is not part of Medicare. So that's an added resource that if people are able or have been buying into a policy, have that, but understanding that that's not part of it. So if someone gets sick and can't take care of themselves and they need long-term care, that's an added expense. So really understanding the program. And I think it's really great to talk about it with kids and family, so that you've got someone else. As you get older, as our parents get older, as people get older, the cognitions, what Michelle was saying, there's lots of things that start to happen. Making sure there's someone else that knows your plan, knows what you're entitled to. And also so that if you're getting bills that might not look right, you've got somebody who can help situate it. For me, with my clients, I'm their point person. So if they get a bill that doesn't look right, they'll call me, which is also why it's important that you've got a trusted advisor in your insurance agent so that they can help and make sure that, you know, you're not getting billed inappropriately or someone's calling you out of the blue asking you for Medicare information. Our elderly population, unfortunately, are getting scammed a lot and taken advantage of. So you want to have someone you can trust and say, is this legitimate? So that we're really taking care of our elderly population.
Mm-hmm.
And it's very important to plan ahead too, because most people don't know that most assisted livings are not contracted with Medicare. They're not required to be, whereas a skilled nursing facility is required to be contracted with Medicare. So when it comes to assisted living, unless they're part of the Star Plus program, which most are not, unfortunately, it's all long-term care insurance if the individual has a policy or private pay.
Mm-hmm. So this is the questions that people need to ask themselves and their family members earlier. Like, it's a mistake to think that everything is under control and covered. The government will think about us, or it will somehow automatically fall into place. So important to ask those questions. And back to the changes that we were talking about, we started mentioning cognitive changes. And I wanted to ask Courtney to tell us more about what she sees in her patients, because she works with people who have dementia. And what are your observations?
Yeah, so I currently work in a memory care community. So family members come to us, and it's unfortunately most of the time it's either really early on before it might even be necessary for a memory care community, or it's almost too late. So they hang on to their loved one for so long for different reasons, caring for them. And now they're at a point where they don't know what to do. So for cognitive functioning, it can be most prevalent in activities of daily living, or ADLs. So as you're caring for a loved one, whether it's a spouse or a parent, you start doing easier things like it could be eating, drinking, going to the bathroom, having to get showered. So like Anna mentioned earlier, if you can kind of watch your loved one in their home setting, you can kind of get a better idea as to if these things are happening. Not taking showers is a big one, and disruptions in their daily routines is big. So we see a lot of clients come to us saying, you know, mom's not showering, she's having trouble eating or remembering to eat, or even cooking for themselves. And it's even simple things cognitively, like forgetting things and then not being able to come back to them later. So that's a really big one. It's kind of hard because as you get older, you know, there's things that happen as you get older. Memory, forgetting things is a one that can happen even as you get older without having dementia involved. But there are certain things like Michelle was saying, stories over and over is a big one. And that's one that we hear all the time. Family members come to us and say, they're saying the same things. They're telling us, you know, every single day, the same stories. And so I think with that and with activities of daily living is a big one that they need help with. And they're starting to realize it's not so easy to care for them in the home setting, are things to look for.
Mm-hmm. Do we have any statistics of how common dementia is in elderly population, and how it was affected by the pandemic, if it changed the numbers somehow? Would anyone like to comment on that?
I can do that. In the United States, 1 in 9 people over the age of 65 and older has dementia. And almost 2/3 of those are women, actually. and which is an alarming statistic. And as far as the pandemic goes, actually, we saw a 16% increase in death in dementia patients during the pandemic. That is likely, it's multifactorial. First of all, those with dementia tend to have higher comorbidities. You know, they have higher rates of diabetes, hypertension, high cholesterol, etc. So, you know, it's not necessarily the dementia per se that made them more susceptible. It was many other issues. You know, during the pandemic that affected them and made them more susceptible to death and illness.
Mm-hmm. And what are the other most common cognitive conditions that make people incapable of being independent, or that ruin their quality of life or lower it? We talked about dementia. I know Alzheimer's is a big one. What other issues are very common in our senior citizens? It would be also a question for Michelle Coffey.
Sure. So I like to think or explain that dementia is an umbrella term. It's a blanket term you used, but under that umbrella, there are a variety of types of dementia. Alzheimer's being the classic one that is most common. There are also vascular dementia, and vascular dementia occurs when there's damage to the brain from things like strokes and underlying vascular causes. Then there's things like Lewy body dementia, which is another form of dementia, frontotemporal dementia. There's different types of dementia, but honestly, many times the dementia is mixed. It's a combination of a few different things. You know, when it comes to treatment, there are a few little nuances in treating, say, Lewy body dementia from a different type of dementia. But in general, you know, with the data shows that supportive care is the best way to support these patients with dementia.
Mm-hmm. Thank you. Since the majority of people watching us, our audience, are women, I would like to ask Michelle Howard, what do you think are the most common issues in women
I would say
related to their physical or mental health?
Sure. I would say number one, for many older women would be UTIs, dementia. Well, we already talked about dementia, but depression's a big one. Osteoporosis, and many people don't know, you know, why UTIs affect many elderly women differently than it would affect a younger adult. Quite often you see delirium, you see falls, you don't see the typical symptoms, you see agitation. And women are susceptible to UTIs as they get older because their bladder muscles weaken, and so they retain more urine, and it causes a buildup of bacteria, and eventually that causes an infection. And unfortunately, we don't always see the common symptoms that you would think with a UTI. You see added confusion. And so I would say UTIs are a big one for women. And I would also say depression and osteoporosis as well. And Michelle could probably add more from the clinical perspective on it.
Oh, Michelle disappeared. Public connection issue. Yeah, it's very interesting. I'm sure a lot of people don't know that UTIs can manifest in symptoms that are not really connected to the pelvic area. You said falls or delirium or confusion. It's a symptom of some mental issue rather than physical. I'm sure a lot of people would find this very useful to track symptoms and look into red flags. Anyone else would like to add about women-related health issues? before we go to the next question? Okay. So let's talk about the topic that a lot of families probably trying to avoid, and to many people it might be a little heartbreaking. The point where you realize, or your elderly relative realizes, that they can't be independent, they can't take care of themselves, and they need to go to some kind of professional care facility. What are the factors that should be considered, and how do we make that decision? Because as Courtney mentioned, sometimes people come too early, sometimes people come when it's already almost too late. So when is a good time to talk about it, and what questions should we ask ourselves? First of all, I would like Anna to contribute to this, because that's what she does every day.
That's what I do. It's never too early to have this conversation. I think a lot of older people have an idea that it's going to be like a nursing home, the nursing home we remember taking our grandparents to, which is just people sitting in wheelchairs in front of TVs. That's not what it is anymore. We've got some great options like independent living, where you're not getting care, but you're getting meals and you're getting socialization in your own apartment. You've got assisted living communities that are beautiful and lots of activities, and care is there. And then, of course, memory care for people that require that when they get to that point of dementia. But I really think it's about having an open conversation and understanding what's going to make your parents or your loved one happy. What are they going to enjoy doing? My mother, for example, she loves art. So she said to me, if we ever have to look for assisted living for me, I want to be in a place that has a wonderful art studio and they do art classes. It's these kind of things to kind of take the stigma away from the smelly old nursing home. There's so many more options out there to make sure that they're safe, but also that they've got a good quality of life.
Mm-hmm. Thank you.
I would say, I always tell people too, when they ask me, how do I know if mom or dad's ready? Where do I start? I don't know how to bring up this conversation. And I always say, start with home health, Medicare certified home health. See if if they have a skill need, meaning PT, OT, physical therapy, occupational therapy, skilled nursing, speech therapy. If they have a skilled need for any of those services, start there. It's 80% covered under Medicare. And from there, see how much more care that they're needing. If they're needing more care, because Medicare certified home health is just short episodes. So it could be a 6-week episode and maybe 3 times a week or 2 times a week. I mean, it's per individual. And the visits are not more than an hour. And so a lot of times they'll realize, or the social worker from the home health will say, I think mom or dad needs a little more help than we're able to provide. At that point, you could start with in-home care, which is non-skilled. However, that is private pay, or if the individual has a long-term care insurance, some policies would cover it. The problem with that, yes, you could schedule 2 hours a day, or you could schedule 8 hours a day, or you could schedule 24/7. It's very expensive, and Medicare doesn't cover it. So that's when you've reached, kind of a standstill, and it's like, okay, we can't 24/7 care with non-skilled in-home care is unaffordable. We need to start looking at assisted living facilities. And that's where I always tell, my clients and friends and family members that come and ask me, start there and kind of let it work its way to the point where, okay, we've exhausted all other options. Now it's time to look at long-term care settings.
I think it's really important to go through that step by step, just like Michelle is saying, because I deal with a lot of people who are in emergency situations that have never had these conversations. And all of a sudden they have to make a very quick decision in a very emotional state. So it's so great to really think about, okay, step 1, step 2, step 3, to really make an informed decision and make sure that your loved one gets the right care in the right place.
Yeah, I'd like to add to some things that we see, like coming from a memory care community, like a big number one reason why families choose to move in is safety is the first. So if you start feeling like your loved one at home is no longer safe, that could be because of maybe the way the home is set up. So it could be safety from cooking, it could be products in the home. So safety is number one, all the way to more extreme cases of flight risk, your loved ones leaving when they shouldn't be, things like that. I think another thing to think about, like Anna was saying, assisted living homes, independent living, memory cares, they're way different than they used to be. A big reason why our families choose to move in, besides safety, is socialization. So self-isolation sometimes occurs, is very common to occur at home. And that's a big reason why families come to us and they say, I want my loved one to socialize. I want them to do things that they love doing. I want these things to be offered daily, and most of the time in most independent livings, assisted livings, a lot of these activities, especially in assisted living and memory care, are offered all day long and all week long in a variety of activities. So that's a big thing to think about, and lastly, of course, if they need extra help with care, like Michelle said, if you're doing in-home care, usually they're only coming for specific times. If you try to do all day long, it becomes very expensive. So if you do choose to do a long-term care facility, there's our community, you do have staff there 24/7, which is really nice and comforting. And then, of course, help with medical needs. So giving meds, passing meds is a big thing. And as you move into the specific dementias, sometimes meds need to be given at a specific time every single day. Routine is very important. So those are all things that you can think about and consider and kind of help you make that decision. If any of those kind of check off your list, maybe it's time to start looking for a long-term care community.
Yeah, it's a tough conversation to have, but when it gets to a point where your loved one is needing 24/7 care and they're adamant about staying home, some of the pros you can talk about of moving out of your home. I know this is a tough decision. I know this is really hard. They're losing their independence, and it's hard. But from a positive standpoint, you can say, you will make friends. You will be around other people. They're not only are you going to be having 24/7 care, but you're going to have a nursing intervention. You're going to have medication management. You're going to have activities director. You're going to have chef prepared meals, a massage therapist. Well, I don't know about all, but I know mine. Assisted living does. But there's so many aspects to it that are positive of trying to get your loved one on board of, okay, I know you want to stay home, but it's not doable anymore. It's not feasible. It's not affordable. We can't do it. And so, talking about the pros of moving into a long-term care setting and everything else that they're getting, aside from the 24/7 care, would be a great way to start.
I also
So
think.
Sorry, go ahead.
Oh, I was going to say, I think that part of the importance of these conversations is normalizing it. And I think what, Michelle, Anna, and Courtney are saying is also to start looking at some of them now when, all we have in our head, and me too, being, a little bit younger, is some kind of sad living facilities for people that are in this position that need extra help. And things have changed drastically. So starting that conversation early and with a loved one that is cognizant, so they can see it and they can be part of the decision, because I do think so much of our, older generation is that they want to be part of the conversations. They want to feel, Michelle was saying, that independence is gone, right? And that's really a struggle for a lot of people. And if they're part of the conversation and they can say, oh, I like a corner room, or I'd like to be facing the water, whatever it is, there's something to be said about, being part of the conversations and feeling a little bit more in control with all of that. So I think that's really helpful. The other thing I wanted to say that was mentioned that I think is a really good point is it's almost like a step process. Michelle Howard was talking about use what you have first, start if you have Medicare approved, then kind of go and kind of get that step up, step down. But also on Medicare, and depending which plan you have, there is, durable medical equipment that's covered. So sometimes it's also recognizing where are some of the smaller needs. What can we do, step by step inside the home to help get the parent used to relying on something else? Because again, it's that pride. I don't need help walking up the stairs, or I don't need that bar in the bathroom, even though for safety and security, they probably do. But starting there and maximizing what they've bought into and some of the benefits that they already have in their insurance or in their policies. And that can slowly start getting them into understanding, here's everything that's available to you, or we've tried X, Y, and Z, it's not working. We need to now go the bigger step. And maybe that's meeting with Anna and doing some tours and just seeing what's out there, so that over the next couple months, as things may or may not deteriorate, we've got some ideas versus, I think it was Courtney maybe who said, if you wait to the last minute and now it's an emergency, it's really hard to think clearly and think rationally when you're emotional and when you're worried about the safety of your loved one.
Yeah, that's. Oh, sorry. I was just gonna say that's what Anna said, but I 100% agree with her. Unfortunately, we see so many situations where they have waited it's too long, it's too last minute. And unfortunately, their loved one is not really in a way to be part of that conversation. They're not cognitively there to be a part of that conversation. And it's really sad and really horrible to witness, and the family members struggling. And it's just kind of like, you waited too long. They're not a part of it. They want to be at home, and they don't understand at this point why they have to now be in a home like this. Mm-hmm.
They definitely want to be included in that's part of their independence, and I can't tell you how many times, which is crazy, that after giving a tour to the actual individual moving in, and either their husband or their wife or their adult, son or daughter, the individual looks at me in the eye and says, "Thank you so much for talking to me, and not just ignoring me and talking to my husband or my wife, or the individual that's with them that's not moving in." They appreciate being a part of it and being included. And I always say, if you could bring them, if they don't need to be transferred, physically transferred over here, and you could bring them ahead of time, absolutely bring them. Let's include them in it. Let's get their opinion. They need to be a part of it. Ultimately, it's about them.
Mm-hmm. I also wanted to ask Michelle Coffey, when you work with patients in a clinical setting, and this kind of conversation arises about in-home care versus assisted living, what's the guidance, what's the practice of having these conversations with the patients?
Those are such difficult conversations. Those are always conversations that are so multifaceted. From a medical perspective, a few things that we look at are functional status. And I know we talked about that earlier, has there been a functional decline that it's no longer safe for someone to live independently? Another thing is, as Michelle talked about earlier, is medication management. One thing we see with frequent hospitalizations and ER visits is oftentimes mismanagement of daily medications. It's forgetting to take your blood pressure pill at the same time, taking 2 blood pressure pills and then getting dizzy, or not taking an antibiotic when you have an infection, and so the infection comes back. Those sorts of things are some of the triggers that start those conversations with families. And it's always so difficult, because that loss of independence is such a huge component also of psychosocial issues, and can lead to things like depression and anxiety. So it's a continuing circle of things that it can affect your overall health and well-being.
Just on a completely anecdotal level, I had a client recently who told me, she said this, it stuck with me, but she was trying to get her mom to move from her home to assisted living. And the biggest fear was kind of that overnight care. They were not able to afford 24/7 care. And she said, Mom, do you remember when I was a teenager and I would go out late at night and you wouldn't know where I was, because this was before cell phones, and you wouldn't know what was happening and you were out of control and you couldn't sleep until I walked through the door safely. That's how I feel every night, because you're in your house and I'm out of control and I don't know how to help you. And I thought that was great, because that is the same feeling. It's that feeling that your loved one is just out of your control and you want to keep them safe. But it's a little bit of a guilt trip, but I liked that she used that example, because I'm a mom and I know that feeling, and I know my mom knows that feeling as well.
Yeah, it's good when people talk about it and there's less stigma about the subject.
Mm-hmm.
Thank you, Camille, for your comment. And I would like to remind our audience, if you're watching on YouTube, you can comment and our speakers can answer your questions live. And now that we mentioned the topic of assisted living facilities, could someone walk us through types of facilities, types of care, and how to distinguish between them and how to choose the right one?
I could talk about the types, or definitely start. So there's two types of assisted livings. There's type A, and there's type B. Type A, you have to be able to evacuate in an emergency on your own. So typically what you see in type A is intellectually disabled. Type B, there are two types of type B. There's a large type B, which is 16 or more residents, and there's a small type B, which are 16 or less residents. So that's the only difference from a licensure standpoint, guidelines, our rules to follow, is the amount of residents had. So a small type B and large type B are mostly consist of an elderly population. Small type B is typically in a residential neighborhood. Most people refer to them as personal care homes or residential care homes, residential assisted living, where large type B would be a facility, the Big Brookdales or Belmonts or Renaissance. There's quite a few of them. So those are the only two types of assisted livings out there. Then you have memory care, which is an assisted living that has a memory care certification. And a memory care would have locked units. That's for individuals with dementia or Alzheimer's that are wandering risk or possibly have disruptive or aggressive behaviors that wouldn't be an appropriate placement in a typical assisted living setting. And then you have skilled nursing facility, which although assisted living facilities type B offer 24/7 care, the 24/7 care in which the caregivers are awake at all hours would be either certified nursing assistants or trained caregivers, where a skilled nursing facility would, in addition to having a skilled nurse or a certified nursing assistant or trained caregivers around the clock, they would also have a registered nurse, a skilled nurse there 24/7 as well.
Mm-hmm. Anna, would you like to add something, because you work with all kinds of facilities and care options?
Yeah, Michelle, that was a great overview. So I guess I'll hit up, how do you choose the right one? Number one, it is about what kind of care you need. So everything that Michelle was talking about. From a more kind of emotional perspective, I have a very long list that I give clients, a checklist of questions to go through. It really is about going into that community and making as many observations as possible. The salespeople are going to give you the sales pitch. That's what they do. But talk to as many residents as you can. See how the staff are interacting with other residents, and are the other staff talking to you? Are they on their phones? Are they looking after people? Pre-COVID, and kind of getting back to that, you could go in for a meal and you could try out the food. You want to ask about caregiver ratios, activities, but really you do get a good feeling when you talk to as many people in that building as possible. There are so many beautiful, beautiful buildings in Austin. I call them my chandelier communities. That doesn't mean that they give the best care. So I always ask people to overlook the design, aesthetics, and all of that, and find out what kind of care you are actually going to get. And then be very, very clear about what is going to make your loved one happy. And really kind of coming at it from that perspective.
Care definitely is most important. And a lot of families, they'll get taken in by the glitzy, bright lights and, gorgeous, gorgeous facilities that are out there. But a lot of times they end up going back to a smaller facility that, his staff has been there for many, many years and knows each and every resident and knows their diagnosis and knows what's going on and knows the care that they need. And so ultimately, what everybody finds out in this situation is that care is most important. Mm-hmm. And I always tell, clients, ask if, they could give you current patients that are residents that live there, to ask, or, previous, residents' families that were at the facility that may have passed away, if they don't mind you calling and getting a recommendation and seeing what they have to say, testimonials, in addition to, resident to caregiver ratio as well is very important as well. And not just, during the day shifts, but how many caregivers do you have at night per resident? Mm-hmm. That's a big one. Do you have a nurse on board? Do you employ a nurse? A lot of assisted livings don't employ a nurse. They just contract them out to do, the mandatory nursing stuff that's needed, such as the monthly MAR or the staff medication training, ongoing CEUs. But do you actually employ a nurse? These are all very important questions. Do you have a full-time activities director? What does your staff look like? What hours are they there outside of the direct care staff that obviously is there 24/7?
Yeah, I have a couple of things to add too. Just a side note, if a family member is in a very early stage and maybe they're just, whether there's cognitive decline or not, if they're just looking for some help, they're not as prevalent now. Prior to COVID, there was several. There's only a couple I can come up with off the top of my head, but there are adult kind of daycare programs. There are a couple memory care focused ones. So since we're talking about dementia, Memory Connections is one of them. You do have to apply to get in. There is a monthly fee for that. Meals on Wheels actually also has a senior program that focuses on memory care, which is really awesome, in Austin. But there's also senior centers. So you'd have to be able to transport your loved one to these groups, but they offer socialization and activities. And if you just needed a couple hours kind of break, that's an option as well. In regards to factors to look into, I think Anna and Michelle pretty much hit everything. One thing we also have seen with people looking into our community is proximity to family members. So if you're looking to move your loved one into a community, unfortunately, we've seen so many times where the loved ones live so far away and they think, oh, it's going to be fine, I'll visit, and then it turns out we've had family members feel guilty later that they're not visiting as much because you think that you'll have time to go the distance and you just don't. And of course, like they said, staffing levels, activity program. I think size of the community matters. Like Michelle was mentioning, I work in a large community, but it just really depends on your loved one and what they're comfortable with, as far as that goes. And then, like Anna said, I think doctor services, ancillary services, other services. Michelle offers massages, which sounds amazing. But there's beauty services as well. So those are all just like little things to look into. But like Anna said, don't be fooled by how beautiful it looks. You really should ask the questions about staffing and going into changes after COVID. There's been huge changes in communities, unfortunately. from COVID. So I think now more than ever, you should be asking the questions like Michelle mentioned. What are the staffing numbers? What are the hours that they're actually there? Do you have a nurse in the building? How often? I think now more than ever, you should ask those really specific, detailed questions.
One that we hadn't mentioned that I feel is very, very important to mention is, can they age in place? At what point if they're going to have to move out of here, what point would that be? I've had a lot of residents come to me from larger facilities because they got to a level of care that the facility said we need more help than we're able to provide. So in order for them to stay here, you're going to have to hire in-home care, private caregivers, which would be private pay, and it kind of defeats the purpose of an assisted living facility. So the family ends up paying, or the resident ends up paying, not only for the assisted living, but overnight private caregiver as well, because the facility can't handle it on their own without a private caregiver. And so one of the big things to ask is, would you ever ask us to do this, or at what point would you ask us to do this? If you don't, a lot of times is if the individual is a 2-person transfer, and if the facility only has one direct care staff overnight, then, by licensure, you're required to have 2 for a 2-person transfer. So that's why they would ask the family, okay, your loved one could stay here, but you're going to have to hire a private caregiver overnight to assist, to be the second person in that 2-person transfer. And that's just one example. There's many different, reasons, but I would ask, give me the reasons why I couldn't, or my loved one couldn't age in place here.
And that's so important right now as well, with staffing shortages and what the facilities are dealing with. And I wish that I could take Michelle and clone her house and dot her all over Austin, because the small facilities like what Michelle has are such great options for people who really truly need 24/7 care. And I am so glad you brought that up. It's such an important point.
So not really knowing some of the terms, I just want to go back to clarify, because this is actually really nice to hear as well. Age in place basically means that they can age until they pass in that same facility. So basically, if they upgrade into upgrade into a different level of care, can they still be treated at the facility, or would they have to find, a higher level care, is basically what you're asking, right? Mm-hmm. Or what people should ask when they're looking at these places.
Mm-hmm. Yes. So, 99% of our residents age in place. They pass away with us. And, when it gets towards, end of life, we would get hospice on board. The same for if they're needing, physical therapy, occupation, we would get home health on board. It's their home. So they would come to their new home, right? And treat just as if they were at their own home. The only reason why an individual couldn't age in place at the assisted living, the long-term care that they're currently at, one, which the assisted living shouldn't have accepted them in the first place, is if they were diabetic and on daily insulin, and say, when they moved in, they were able to give themselves their own insulin. But if it got to a point where they can no longer give themselves insulin, then they wouldn't be appropriate for an assisted living facility. They would have to be transferred to a skilled nursing facility, which has a skilled nurse there 24/7. Another example would be if now the state actually does allow assisted livings if the nurse delegates it as a health maintenance activity for like a feeding tube. So some assisted livings would take feeding tubes, but we've never felt comfortable taking feeding tubes. A resident moved. The one time I did have to transfer a resident is a resident moved in, and she did not have a feeding tube. She had end-stage Alzheimer's. And the family decided to put a feeding tube in her she was 98 years old. And so unfortunately at that point we had to transfer her to a skilled nursing facility. Another example would be if an individual had aggressive or disruptive behaviors that were dangerous to other residents in the home. But it's very rare, other than those specific reasons, or if an individual became a wandering risk. Maybe they moved in and they weren't wandering initially, but then they started to wander. That, for their own safety and ours as well, they would need to go to a memory care unit. But other than those few reasons, and y'all let me know if I'm missing one, there's no reason why an individual shouldn't be able to age in place at an assisted living facility.
Mm-hmm.
One thing I also wanted to mention, and it goes along with what Michelle is discussing here also, is the importance of making sure to choose a facility that has an integrated medical provider, typically that rounds at the facility and comes to see your loved one at the facility. Not only is it more convenient, but also, one of the issues I see is that someone will take their family member to a primary care provider, and they prescribe a medication that, for instance, insulin, not understanding the nuance of the facility and not understanding the limitations that they have, and that, having a, twice daily or once daily insulin, which is a very normal prescription for many people, is not sustainable in many environments. And then also making sure that the progression of illness is able to be sustained at the building. Like Michelle said, not every assisted living has the same types of care. There are some assisted livings that absolutely will not do a 2-person transfer. There are some that will only do a standby assist. Everyone is different, and it's important that the medical care and the medical treatment of your loved one reflect the environment of which they're living in. And if it does not, what does that mean? What does that look like to the patient? What does that look like to the family member? And to make sure everybody is on the same page about that. Aging in place is an absolute wonderful goal. And if that is the goal, let's have discussions and let's let our care reflect that goal. And that's an extremely important conversation to have on an ongoing basis.
Absolutely.
Mm-hmm. I also wanted to ask Michelle Coffey about the big elephant in the room, COVID, because we talked about how people in isolation, they develop depression, so they need to be socializing. But now we know that socializing comes with these risks of catching COVID or spreading COVID, even if you're double, triple vaccinated. So is there an answer to that? What do we choose between depression and COVID when you're in home or in an assisted living in any kind of setting?
What a loaded question. I'm I'm currently in a building with a COVID outbreak, as reflected by my very closed environment. It is so difficult. COVID has greatly impacted so many facets of senior care. Early on in the pandemic, the social isolation was heartbreaking. It was a huge issue. We had a large increase in the number of patients with depression, also worsening of dementia. It worsens dementia symptoms when you have all of a sudden their routines changed. They're not seeing their loved ones on a routine basis. They're not going to bingo on a Tuesday afternoon. Those types of changes really can accelerate dementia symptoms. And it was so heartbreaking as a medical provider to call the family and tell them this. And they had absolutely no way of really sort of seeing it for themselves and validating that. It's extremely difficult. Now, I will say this: with the widespread distribution of vaccines and boosters in the Austin area, it has changed senior care in the last year or so since we've really been able to vaccinate our loved ones. We have a very high vaccination rate in our senior population, and it really has made COVID, it's difficult, but it's not what it used to be. In fact, just to give you, I'm currently treating quite a few patients. Over half of them have minimal to no symptoms with the new Omicron variant. These residents are vaccinated and boosted. That's the big difference. And so with that, we are able to offer more supportive care. Additionally, what we have learned is that with the medical issues of COVID, you have to really balance the psychosocial issues there. And it's really fostered actually a lot of good discussions. I've had a lot of positive discussions over the past 2 years with families and patients saying, what are your goals? Is your goal to live to your 100? Or is your goal to see your family members on a daily basis? Is it to play bingo every Tuesday? What are your goals? And let's center your care around those goals, understanding that there are risks associated with those goals, but that's okay. We can take steps to mitigate those risks. And I think treating patients holistically, understanding risks versus benefits, treating their medical conditions with their psychosocial issues, it's really opened up wonderful conversations and wonderful discussions with families. And I think we've also learned, medical care is not just about pills and treatments. It's about those relationships. It's about families. It's about discussions. And it's about creating a positive and loving environment in whatever setting that you're in.
Thank you. And unfortunately, it's been 1 hour already, and this conversation is endless. And I'm encouraging everyone who's watching us to reach out to our amazing experts. If you have any need, they will be happy to answer your questions. And to close this conversation, I would like to ask every panelist to give one tip of advice of how we can be more supportive of the senior community, senior population, how we can improve maybe by one little thing their quality of life today, or just make them happier in this rough times for everyone. So I'd like to start with Courtney.
Yeah, so I have a whole list, but I'll just try to say one. I think coming from a community perspective, one thing that we can do as a community to be more supportive is be a companion, volunteer if you can, inside a community, definitely outside of a community for other senior organizations. But inside a community, there's so many different things that you can assist with, from just hanging out and talking with someone, but just being there, being that person to interact with them. Family members come, and some come every day, but some don't. So on those days, it's really nice to offset with volunteers and just be able to have that buddy system. So if you have any time in your schedule at all, right now, kids are welcome back in communities for some. So, that would be great. We have a lot of volunteers that come and just bring their kids, and they get that intergenerational interaction, which is great as well. So if you can, just volunteer for a community.
Thank you. Anna?
Off the back of that, specifically Meals on Wheels Central Texas desperately needs drivers. I think they have a need for 250 drivers right now. They were supposed to return to regular meal deliveries, but Omicron kind of threw a spanner in that. So it's a really great organization. And right now you can kind of dip in and out as you need to, but it's a really fantastic and easy thing to do over your lunch break, to really just make a senior's day and just say hello, drop off some food, and feel the warm fuzzies.
Thank you.
I would say continuity of care, starting with, proper placement, proper discharge planning, care plan meetings as a whole, and just taking more of a team approach for everybody that is involved in the seniors' care, and not just one group or one provider, but taking the entire team approach.
Thank you.
I think I would say that we should all have more grace with each other, especially our, older population parents. And I think on the heels of what you're saying with congruency, is have more grace with, the parent that's a little stubborn, and then also really dig into those conversations so that you can help make sure that there is congruency. And even in those conversations, just have grace, because I think that the pandemic for our older populations, as we've talked through this whole hour, but it's really affected them more. I think that for younger populations, they can see getting through, and we can see 20 years after the pandemic. But for some of our older population, it's harder to see that. So this has been really trying on them emotionally, physically, all of it. So there's some new stubbornnesses or just new ways that people are going about things. And I think having grace with everyone is a really good first step.
Thank you.
And my advice would be to listen. I think a lot of times our older population, their voices don't get heard. And they have many wonderful and very insightful things to say regarding what has happened, and then is also regarding their future and their care. And I do think their voices often are not heard properly. And I really hope that more people take time to just listen and take the time to understand and actually hear.
Thank you. This is a great piece of advice. Thank you to all our panelists for joining us today and for everything you're doing every day to help our families, senior population, and just the community in general get through the pandemic, stay healthy and happy.
Thank you.
Thank you.
Thanks,
Thank
Olga.
you.
Thank you.
Thank you. Bye, everyone.